So over to you, Dr. Sushmita, to cover the very interesting topics on phenotypes in congenital pediatric glaucoma dictating treatment decisions in Asia. Where would she take it, here or there?
Thank you so much, Dr. Kirti, and thank you for the opportunity for this IC. So I'll be talking about why does a phenotype in congenital glaucoma matter. So childhood glaucoma is very similar on the surface. It has, all C's look the same, but believe me, there are myriad hues underneath. And as for all glaucomas, childhood glaucoma is not one box into which all the children are kept. So at the outset, I'd like to say that we do take informed consent from the parents, because I tend to show identifiable pictures of the babies because that puts it in context. So in today's next 10 minutes, I'll just describe what we've learned along the way, and I'm sure we have a long way to go. And we'll have snapshots of phenotypes and one or two pearls on the importance of phenotyping. Why is it that you should do that? So coming to one of the pediatric glaucomas when you do them, if you have acute eye drops. If you have a parent or a mother saying this baby was perfectly fine 2 days ago, or dekho aaj kya ho gaya, in the ER, inward you're saying now it's good because you're going to be God. And if you see that, can I have a pointer? Aapke paas hoga? If you see that on the right side, that's the Harb striae which has really stretched out, which is why the aqueous has gone straight into the eye. And you have the acute eye drops, and the picture on the bottom is actually how much they cleared with just giving an anti-glaucoma medication. So this is with dorzolamide. And you do a combined trab with trab, and it's a miracle. Within 4 to 6 weeks, it absolutely clears, and you really become God. The importance of this is not just understanding that you have to do it early before scarring sets in, but also the fact that we've also noticed that acute eye drops happens in the contralateral eye once you do surgery in one eye. And we saw many children with this, and it changed our practice to treat both eyes simultaneously. But this was pre-COVID, of course. COVID has taught us to do bilateral simultaneous glaucoma surgery for all our babies, and now, so this really doesn't matter. But at that time, when we saw acute eye drops, you did one eye, and he came back with the next, and then you did both eyes, which did well.
Audiovisual, please put the timer on. The timers are not on.
Right. So going further, now that we are in the era of MIGS, and I can say I'm a very happy gatter. So we wondered whether we could do this in acute eye drops, and actually, sometimes you realize that even though this is so hazy, superinasally, it's still a little clear. And we'll just take you through the next couple of seconds that we manage the goniotomy, you manage the proline, and as you go in, actually, you might actually get away with a GAT in acute eye drops. So that's a learning for us, that all white corneas are not amenable to angle surgery. If you can manage a GAT, even in an eye like this, they do clear quite well, and they clear as miraculously as a CTT. Coming to neonatal onset congenital ectropion uvea, it is the most horrible glaucoma that we know. These are what these children look like once you do the surgery. There's ptosis, there's a pannus, and there's a spindle-shaped corneal opacity, which Dr. Ken Nischel has described as CYP1B1 cytopathy. We described this phenotype in neonatal onset glaucoma, which were hitherto all PCG. It's not true. You can see that ectropion. If you see ectropion uvea in a newborn baby, you can be sure that you're in trouble, because that's a really, really bad glaucoma to have. This is the same baby that has come after the surgery. And we also actually identified a common genotype in all of them, the arginine 398. So it's also a genotypic marker if you have this phenotype. Prognostication is important, and it's important for you to know that these corneas are never going to clear. They'll either land up in an optical iridectomy, like this child here, or they'll land up in an OPK, which is another ballgame in itself. So this baby really started our rubella journey. UBM, if you see a zonular cataract, you have to think rubella. And when we started doing the rubella testing in our neonatal babies, the hallmark of the phenotype is a small eye, white cornea, high IOP, and optic disc cupping on ultrasound. And if you see this triad, this phenotype, you have to look for a cataract, you have to evaluate hearing, and you look for cardiac defects. And you'll be surprised at how much we miss and how many of these children grow up to be developmentally delayed when actually they just can't hear. Congenital primary aphakia is important to recognize because to avoid the disaster that I had before I recognized this, the silvery blue hue. And once you start recognizing them, you'll realize you have many, many more in your clinic. Don't just dump them as an anterior segment dysgenesis, first do no harm. There will be an absence of a lens, but believe me, once you recognize what they have and you recognize that they just don't have a lens, you give them high plus glasses and they actually see and they are mobile. And high plus doesn't mean plus 10 or 12, it means plus 14, plus 17 sometimes. And they walk around, they're fine, and they'll hate you taking their lenses off. So recognize this condition so that you can rehabilitate them better. This is my pet peeve now. Is aniridia a disease or is aniridia a phenotype? Is aniridia absence of iris and disease, or is it just that absence of iris? So this is garden, usual aniridia, and autosomal dominant, so the entire family, all children and the mother have aniridia. You have foveal hypoplasia, you have a smallish eye, and you have limbal stem cell deficiency, and of course you have PAC6. So if you have PAC6, autosomal dominant, that's that. So here is a preterm. And all of us think it comes white. You do a combined trab with trab, there's aniridia, there are stumps of the iris on the UBM, and you think you're fine. You get a genetics done because the family wants it, and lo and behold, it's FOXC1, complete gene deletion. And you learn that a complete gene deletion of FOXC1 is an Axenfeld with no iris formed. And when we look further, now the child has grown a bit, you can see the telecanthus, you can see the periumbilical skin, which you didn't look for because you just assumed it's aniridia. And these children don't need Wilms tumor screening at all, simply because there's absence of an iris. Now what about this? Again, a 2-month-old, absence of iris, no iris at all. Is this aniridia? Yes, we thought it was. So this was also named aniridia, except that it was just absence of iris. Did a bilateral combined trab with trab? Well, lo and behold, CYP1B1, arginine 398. We didn't recognize a CYP1B1 cytopathy. This was neonatal onset CU with severe iris hypoplasia. If you have absence of iris and no nystagmus, it's good, because then it's not PAC6 aniridia, there's no foveal hypoplasia, there's no limbal stem cell deficiency, and there's no risk of Wilms tumor either. And they are not autosomal dominant. They are all autosomal recessive diseases, so it's likely that the child might be a carrier. You have some hope for this children. So to summarize, I think clinical examination is a hallmark of management of childhood glaucoma. And why childhood glaucoma? It's a hallmark as for all others. Ensuring good vision is our goal and not just IOP control. Look out for the family. But remember, once you start taking care of these babies, you need to hold these children's hands lifelong. But it's been a pleasure, and it's been really, really nice to be able to be a part of their lives. I take the opportunity to thank, these are from Deepika to Faisal down, all my senior residents who work hard, really, really hard, so that I get where I am. And I invite you all to the Indian Pediatric Glaucoma Society. This time it's at Madurai in December. Believe me, you'll see a lot more of these stories as all of us tell our tale. Thank you.
Thank you. Yes, please. Dr. Sushmita has a comment for you, and Dr. Siddharth, you can just load your slides. Mic, please.
Hello.
Yes, sir.
She has mentioned about congenital rubella syndrome, and that is a totally preventable syndrome. If we vaccinate all children, or if we vaccinate all adult females who are going to be married or just before married or at the time of roka or ring ceremony, then we can prevent congenital rubella syndrome. Because if rubella happens during first few weeks of pregnancy, 90% of the children, they will be born with congenital rubella syndrome, including congenital glaucoma, congenital cataract, microphthalmia, choroidititis, besides other heart and other abnormalities. So that's why I wanted to.
True, I agree, yes.